Obstructed hemivagina with ipsilateral renal agenesis, OHVIRA syndrome, otherwise called Harlin-Wunderlich syndrome. This was seen in a 19-year-old student who underwent an exploratory laparotomy 6 months prior to presentation on account of cyclical lower abdominal pain and abdominal mass. She had an ovarian cystectomy and a vaginal procedure. On pelvic examination, we observed that the clitoris was absent, and apparently it was iatrogenic, so we're not sure of the type of vaginal procedure done for the patient. She reports regular menstrual cycle, but continues to experience cyclical pain and abdominal swelling. This history was what guided me to suspect OHVIRA syndrome because she menstruates regularly, but at the same time, she complains of cyclical lower abdominal pain and swelling. OHVIRA syndrome is characterized by uterine diadelphys, obstructive hemivagina, and ipsilateral renal agenesis. So it's a result of failure of lateral fusion of the medullary ducts, and there's presence of longitudinal vaginal septum with one side obstructed, and this is the side where the hematometria will collect. There's obstructed renal agenesis on the same side. This patient presented with all these features. She had cyclical pain, had dysmenorrhea, there was pelvic mass, and then she menstruated normally. So this patient presented with all these features. So now, before we look at the video, I made a schematic diagram of what we shall see on the ultrasound image. So here on the right side, we will see hematometra with obstruction somewhere around the cervix or upper vagina. On the left side, we will see a normal uterus. So she menstruates via the normal uterus. Why? Because of this obstruction, the blood collects, and this forms the pelvic mass and explains the cyclical lower abdominal pain. On the right side, where there is this hematometria, there was no kidney. On the left side, there was a multilocular ovarian cyst. Remember, she had cystectomy 6 months prior to presentation. So we are not sure of the laterality of the lesion. But here, we observed a multilocular ovarian cyst on the left side. On the same side, where the kidney was present, there were evidence of back pressure, probably from the ovarian cyst. It could also be from the previous surgery, or there may be some anomalies associated with the renal system. So now let's play the video. So here you can see this is the bladder. You can see the normal vagina here. Here you can see part of the hematometria here. This is on the right side, represented by this here. So this is the hematometria. So here you can see the isthmus, and here is the fundus of the uterus. This is the obstructed hemivagina. You see that? So this is what is depicted here. You can see that. You can see the hourglass appearance of the hematometria. This is part of the multilocular ovarian cyst. This one on the left side. So shortly we shall see the menstruating or the normal uterus. Again, you can see the multilocular ovarian cyst. So look at the uterus here. Look at the secondary endometrium here. So this is this uterus where she menstruates. So you can see that. So this is a case of uterine diadelphys, obstructed hemivagina with ipsilateral renal agenesis. So we shall see the renal agenesis shortly. So, but here you can see the normal uterus with this secretory endometrium where she menstruates. This is part of the multilocular ovarian cyst on the left. So now, again, you can see the evidence of obstruction here. So here, the liver, you can see there is no kidney on the ipsilateral side. So obstructive hemivagina with ipsilateral renal agenesis. This is a gallbladder. So you can see there is absence of the kidney on the right side. So we shall check the left side and see. So look at the kidney on the left side, this kidney, and look at the evidence of back pressure. So this is a case of obstructed hemivagina with ipsilateral renal agenesis OHVIRA syndrome. Because the patient was in pain and we couldn't carry out the definitive surgery at the moment, so we decided to relieve her symptoms by doing an ultrasound guided drainage of the hematometria. So at this, she has temporary relief of symptoms, and we decided to induce amenorrhea until we prepare the patient for definitive surgery, which is excision of the septum. So you can see that this is within the uterus under ultrasound guidance. Patient was given, or the area was infiltrated with local anesthesia, although the temperature of the patient was low. So it was a little bit of a challenge draining hematometria. So as you can see, as the procedure progress, you can see the content reducing gradually. So these are the still images. Here you can see the normal uterus here, the hematometria here. Here we just measure the distance between the anterior abdominal wall and the uterine cavity so that we determine how far the delivery will go. So you can see the volume of the hematometria was about 400. After that, it's reduced to 58, so it's significant. This is a 3D image. You can see the blind ending pouch, the obstructed hemivagina, and this was the hematometria drain and ultrasound guidance. Here was the left ovarian cyst. And you can see the back pressure on the kidneys here, probably due to the this ovarian cyst, or it could also be due to the adhesion from previous surgery, or probably some associated urinary tract malformations. So I think a message here is that a meticulous history will help in clinching even the rarest of conditions. This is a very rare condition. In fact, I've never seen this case in my practice. But the history of regular menstruation associated with cyclical lower abdominal pain and the findings on ultrasound of hematometria with the normal uterus suggest this is a case of OHVIRA syndrome. The gold standard for diagnosis is, of course, magnetic resonance imaging, but we can see here with even transabdominal ultrasound, so we are able to arrive at the diagnosis. But of course, MRI is the gold standard. We temporarily relieve our symptoms before the treatment because we have to prepare this patient. This is a 19-year-old secondary school, she had a surgery, a laparotomy, where a varicestomy was done, and then she had some vaginal procedures that we were not sure of. But what we observed was that the clitoris was absent and it was obvious that it was iatrogenic. So we need to plan this patient. So, and we don't want her to menstruate, because if she does, she will come back with cyclical lower abdominal bleeding, with lower cyclical lower abdominal pain. So we decided to induce amenorrhea in this patient. So thank you very much for listening.